All right, let's talk about a topic that's pretty much guaranteed to show up on your anesthesia exams: pulmonary atelectasis. In this explainer, we're going to break down exactly why a perfectly healthy lung can start to collapse the second anesthesia begins, and more importantly, we'll cover how you can master managing it.
So, here's how we're going to tackle this. First, we'll get a crystal clear definition. Then, we'll go through the key risk factors you absolutely need to know. After that, we dive into the really juicy stuff, the physiology of how it happens. And finally, we'll bring it all home with diagnoses and the practical strategies you'll use every day.
So this is the big question, right? It just doesn't seem to make sense. You have a healthy organ, and all of a sudden it's struggling to do its most basic job. But trust me, if you can really get your head around the why behind this collapse, everything else is going to click right into place. So what exactly is atelectasis? Well, the name itself comes from Greek, and it literally means imperfect expansion, which is a perfect description. It's when those tiny air sacs, the alveoli, just collapse down. This obviously messes up gas exchange, and it creates what we call a shunt. That means blood is just flowing right past the collapsed parts of the lung without picking up any oxygen. Okay, so we know what it is. The next logical question is, who gets it? Being able to spot these risk factors before you even start is a massive part of planning a safe anesthetic. Now, for your exams, the best way to not forget any of these is to just categorize them. It makes it so much easier. You can just drop them into 3 buckets: things related to the patient, things related to the anesthetic itself, and things related to the surgery. Simple as that.
And when you actually look at this list, what's kind of crazy is how common all this stuff is. I mean, on the patient side, you've got obesity and age. With anesthesia, almost everything we use is a risk, especially high oxygen. And for surgery, just having the patient lie flat on their back is a risk factor. And that's before you even get to big operations like thoracic or laparoscopic surgery.
Okay, deep breath. We're now getting into the absolute core of this whole topic. If you can really nail the physiology on these next few slides, you'll have a rock-solid foundation for everything else. So let's break down exactly how this happens. It all comes down to 2 key volumes. First, you've got your functional residual capacity, or FRC. Think of this like a safety reserve of air in your lungs. It's the air left over after a normal breath out that kind of splints the airways open. Then you have the closing capacity, or CC, and that's the tipping point. It's the volume where those small airways start to shut down.
So, in a healthy person who's awake, like you right now, your FRC is way higher than your closing capacity. Your safety reserve is always bigger than the collapse point. Everything stays open, everything's stable, totally normal.
And here's the problem. The minute we give a general anesthetic, that FRC, that safety reserve, shrinks a lot. The diaphragm relaxes, the chest wall changes, and boom, suddenly your FRC drops below your closing capacity. And now, with every single breath out, airways are collapsing. That's the whole game right there.
Now here's a really important concept. The real damage isn't just that the lung is collapsed. It's the repetitive, constant opening and closing of those little airways with every single breath from the ventilator. That shearing force causes actual cell injury. We call it atelectrotrauma, and it's a huge driver of ventilator-induced lung injury.
So how does this actually happen? Well, there are basically 3 main ways. The first one is simple: compression. The abdomen pushes up on the diaphragm and squashes the lungs. The second is absorption. This one is pretty cool. When we use high oxygen, it pushes out all the nitrogen that normally helps keep the alveoli open. The oxygen gets absorbed into the blood so quickly that the alveoli just deflate like a balloon. And third, you can get surfactant dysfunction, where the stuff that prevents the alveoli from sticking together stops working as well. So we know what it is and why it happens. How do we actually spot it when we're in the operating room or the ICU? Clinically, right at the bedside, your first clues are the classic signs. You listen with your stethoscope and you hear quiet breath sounds or maybe some crackles. You look at the chest and see it's not moving as much. But honestly, the first thing you'll probably notice is the oxygen saturation dropping on the monitor. And if the patient is breathing on their own, they'll start breathing faster to try and compensate. Sure, you can get a chest X-ray, and it'll show you the collapse, but that's just a static picture. For a real-time, dynamic look at the bedside, nothing, and I mean nothing, beats lung ultrasound. It's fast, you can do it over and over, there's no radiation, and you can literally watch the lung change breath by breath. It's a game changer. And look, the evidence for this is just overwhelming. Study after study shows that lung ultrasound is way more accurate than just listening with a stethoscope or even getting a portable chest X-ray. And you're doing it all without zapping your patient with any radiation. It's a no-brainer. Okay, this is the really practical part. We know the problem, we know the causes, we know how to find it. Now, what do we actually do about it? This all falls under the big idea of protective ventilation. So, a lung protective strategy isn't just one single thing. It's more like a toolkit, a whole bundle of things you do together. Use low tidal volumes so you don't overstretch the lung. You use PEEP to keep the airways from collapsing at the end of a breath. You can do recruitment maneuvers to pop open what's already collapsed. And you use the lowest oxygen concentration you can get away with to prevent that absorption atelectasis we talked about.
But that brings up the million-dollar question, right? We all know we should use PEEP, but how much is the right amount?
You know, setting the right PEEP is a true balancing act. If you set it too low, you get that damaging open-close cycle. That's atelectrotrauma. But if you crank it up too high, you start to overstretch the healthy parts of the lung, which causes a whole different kind of injury. The goal is to find that sweet spot right in the middle, where the lung is the most compliant and happy.
And this is where another critical number comes in, driving pressure. All it is the change in pressure with each breath. You just take your plateau pressure and subtract your PEEP. And this number is probably the single best marker we have for how much stress the lung is under. In fact, a really modern way to set PEEP is to adjust it up and down until you find the level that gives you the lowest possible driving pressure.
Now, what if you already have a big collapse? You might use a recruitment maneuver. The idea is simple. You give a short, controlled burst of high pressure to pop those lung units back open. But, and this is the most important part, it's totally useless if you don't immediately follow it up with enough PEEP to keep them open. The mantra is, open the lung and keep it open.
And remember, our toolkit extends beyond the ventilator in the OR. After surgery and in the ICU, things like high-flow nasal oxygen, CPAP, and even something as simple as putting a patient on their stomach, proning, can be incredibly powerful ways to reverse atelectasis and boost oxygen levels.
And that leads us to a really interesting final thought for modern practice. We know that being too aggressive with recruitment maneuvers has risks. So do we always have to chase a perfectly clear, open lung on the X-ray? Or is there a place for something called permissive atelectasis, where we actually accept a little bit of stable collapse to avoid the potential harm of forcing it open? That's one of the biggest debates happening in respiratory care right now.